From the JAMA Network, this is JAMA Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA.
Hello and welcome to our listeners around the world. You're listening to JAMA Author Interviews. I'm Dr. Preeti Malani, JAMA Deputy Editor. Thanks for joining us. Today we are discussing an article titled Invasive Group A Streptococcal Infections in 10 U.S. States, 2013 to 2022, by Dr. Christopher Gregory and colleagues, which was published on April 7, 2025 in JAMA. The authors reviewed clinical, demographic, and laboratory data for invasive Group A strep infection cases that were collected as part of population-based surveillance through the U.S. Centers for Disease Control and Prevention's Active Bacterial Core Surveillance Network. In terms of key findings, the authors report that the incidence of invasive Group A strep infections rose from an estimated 3.6 per 100,000 persons in 2013 to 8.2 infections per 100,000 persons in 2022. They also observed that the incidence of Group A strep infection was highest among persons aged 65 and above, although the relative increase over time was greatest among adults aged 18 to 64. Incidence was also higher among American Indian, Alaskan Native persons compared with other racial groups, and persons experiencing homelessness, people who inject drugs, and residents of long-term care facilities had substantially elevated Group A strep incidence rates. The article was accompanied by an editorial written by Dr. Joshua Osowicki from the Murdoch Children's Research Institute and the University of Melbourne, Australia, and Dr. Theresa Lamagni from the United Kingdom Health Security Agency in London. I'm pleased to be joined by both of the editorial authors to discuss the study's findings, as well as what's been happening more globally around invasive Group A strep infections. Josh and Theresa, welcome.
Thank you, Preeti.
Thank you.
To begin our conversation, I'd like to talk about the clinical aspects of serious Group A strep infections. Josh, you're a pediatric infectious disease physician. Why are these infections so important clinically?
Thanks, Preeti. So to be blunt, because invasive infections caused by Streptococcus pyogenes, also named Group A streptococcus, are unpredictable and they're deadly. And this is the same bacteria that everyone listening is familiar as the cause of strep throat or impetigo. But what we're talking about here is a completely different beast clinically. Clinicians caring for adults and children are really haunted by these cases of invasive Group A streptococcal disease. And I bet everyone listening, and Theresa and Preeti, could probably close their eyes and see a patient with invasive Group A streptococcal disease from their past who is a reminder of just how terrible this disease is. We struggle to diagnose patients with invasive Group A streptococcal disease until most of the damage is done. These cases regularly test and often best the most capable high-tech hospitals in the world. And so while we know that penicillin kills this bacteria reliably in a tube, it takes teams, ICUs, physicians, doctors, rehab physicians, and so many others to treat these patients in hospital. Unlike sepsis caused by Haemophilus influenza type B or meningococcus and pneumococcus, we don't have a vaccine to prevent invasive Group A streptococcal disease.
Thank you, Josh. And there are a few things that really strike fear into the hearts of clinicians as invasive Group A strep infections. So let's move on to epidemiology. Theresa, you've been thinking about these infections globally for quite some time now. And the article by Gregory reports an increase in infections in 10 U.S. states. But this is not an isolated observation. What can you tell us about Group A strep infections worldwide?
Thank you, Preeti, for the question. So the sad thing is that we actually don't have good surveillance in most countries worldwide. So this kind of analysis that Chris Gregory and colleagues have done in CDC, which is phenomenal, it's just not possible in most countries in the world. And the countries where the burden of disease is likely to be highest, we do not have good data. We don't have any data, in fact, for most of them. So we're really left with the countries that do have good surveillance, such as CDC's data, and those are mainly high-income countries, and those will be in different continents, so in Europe, in North America, as well as Australia, New Zealand, and a few other countries. And what those have tended to show is a similar pattern to what has been identified in CDC's paper of a longitudinal increase in this invasive Group A strep infection, so very concerning trends over time, particularly in this sort of 10-year period that Chris and colleagues have highlighted in their paper.
The next question I want to ask both of you. We have a great deal of information on group A strep, including molecular characteristics, including antimicrobial susceptibility. What do we know about why these increases in group A strep are being seen? Josh, maybe we'll start with you.
So this is a difficult question, and as with all infectious diseases questions, it comes down to some kind of host and organism and environment concept, and pulling apart each of those can be really hard. The answer is all of the above usually. So you'll read from microbiologists, you'll read about new strains and variants that produce various toxins that perhaps are more virulent. And from immunologists, you'll read about periods of reduced exposure, like during COVID-19, in young children, perhaps increasing the susceptible population to disease, and that changes transmission dynamics. And clearly, we see other environmental influences, and that's really revealed, I think, quite stark in the paper by Dr. Gregory and his colleagues. And that's homelessness, injecting drug use, living in a residential aged care facility, close contact, like that. Much of what we think we know about group A streptococcal transmission prior to the work of the CDC and researchers like Theresa over the last 25 or so years comes from close quarter studies in the US military in the 1940s and 50s. So, it's very clear that there's an environmental aspect as well as a host and organism aspect. But I think that when we take any one thing in isolation, I think we miss the big picture.
Theresa, would you like to add anything to Josh's comments?
Yeah, so the paper has highlighted changes in the strains that are circulating in the US. And so it highlighted a proliferation of less common strains, really haven't been seen in this population. And these are particularly strains that are associated with skin and soft tissue infections, which fits also with the picture of increasing infections in the homeless and in individuals who inject drugs. So I think this all ties together and paints a picture of what might be happening in the US population. Now, when we do longitudinal surveillance for invasive group A strep disease, we do see changes over time. New strains emerge regularly. It's part of a normal evolutionary process. And it may be that some of these strains will die down. So they're kind of common now. And EMM49 is one that's particularly highlighted in the US. And that's now our number one strain in the UK as well. So that's also affecting our population. So it's a question of watch and wait, maintain those surveillance systems so we can understand what's happening and assess those strains, try and work out, are they associated with increased pathogenicity? Are they more likely to cause serious infection in these patients? Really as a way of understanding what's happening in our population.
Thank you. It all really underscores the importance of surveillance, as you noted in your earlier comment. So let's talk about prevention moving forward. Josh, what are some of the priorities in this area? Or, more simply, can group A strep infection be prevented? If so, how?
So there are absolutely things we could be doing to address the unmet public health challenge of group A streptococcus and its global burden of disease. This is not a new problem, and even prior to the advent of penicillin, we read of outbreaks of scarlet fever, epidemics of scarlet fever, a term used at that time to encompass all of what we're talking about as well. We know that 100 years ago in the US, there was a vaccine essentially for invasive group A streptococcal disease developed by George and Gladys Dick at the University of Chicago. A vaccine that we couldn't reproduce in exactly the same way these days, but a vaccine nonetheless. And we don't have a vaccine. We very much like a vaccine. The painful reality, I think, is that without a vaccine, we really lack effective tools to prevent invasive infection at a population level. That 80 years after the advent of penicillin, group A streptococcus is still here. It's still a menace, and we've not been able to eliminate it as a public health problem just using antibiotics. When we think about close quarters that we were discussing before, antibiotics can be effective, we think, in preventing secondary cases. So stopping outbreaks, perhaps in a residential aged care facility or amongst people experiencing homelessness, perhaps in households. Antibiotics may prevent those secondary invasive cases. Still, that's not really a scalable approach at a population level, and there are some doubts regarding the efficacy of that approach anyway. So clearly the burden of group A streptococcal disease follows a cruel social gradient. So we've discussed poverty, malnutrition, household crowding, homelessness, injecting drug use, belonging to an Indigenous community. And I think it's really important in these discussions that we don't consider social inequality and injustice as a constant. These are modifiable exposures that we're talking about. But ultimately, though, I'm a bit of a vaccine nihilist or fanatic. I desperately want to see a group A streptococcal vaccine have the impact, replicate the impact, the spectacular success of meningococcal, pneumococcal, Haemophilus vaccines in reducing severe community-acquired sepsis and the huge impact of other group A streptococcal diseases, such as rheumatic heart disease, which kills more people every year than invasive group A streptococcal disease even. So I'm excited. I'm really filled with hope about vaccine development for this pathogen. There are national and global initiatives that are working really hard and engaging across, everyone that it takes to get vaccine development done. And this is, for me, I think, a really key piece of unfinished business for immunisation. It's one of those pathogens that causes a pandemic in plain sight. And because we haven't succeeded in controlling it, we look elsewhere for easier targets. But this is one of those hard targets that I think we really need to commit to dealing with.
Theresa, you've also done a lot of work in group A strep prevention. Do you have additional thoughts on that?
Yeah, absolutely. And, I echo Josh's comments that we absolutely desperately need a vaccine for group A strep. And it's something that the World Health Organization recognized very strongly and published a report last November, in fact, and placed it at the top of the list of the urgent pathogens for which we need a vaccine. But we're not there yet. So what can we do? And there are things that are effective and do help. And clearly, in terms of the day-to-day things that can be done by clinicians and by the wider system, effective clinical management of everyday group A strep infections, so those ordinary things like sore throat, skin infections, and so on, is really important. If people don't receive antibiotics, they remain infectious for a long time, which means they spread the infection to other people as well as having a risk of complications themselves. So that's why I think in this paper, Chris Gregory and colleagues do really emphasize the importance of access to healthcare as a means of preventing the transmission of these infections and controlling their spread. So that's one thing. And the other thing is around outbreak control. And that's really, really important. So it starts with having systems in place to detect that you have an outbreak and then going in and doing what you can to try and control these outbreaks, which is difficult. I spend an awful lot of time joining in these outbreak control team meetings to try and work with local teams around the country to control them. But there are things that can be done. And really the advent of whole genome sequencing has actually revolutionized our ability to detect these outbreaks early on, understand we have a problem, go in, identify the source of these outbreaks, how they're being transmitted, and put in place those control measures. So that's really key as well. So I think all of those things together are a package, and those are things that we can positively do whilst we wait for the vaccine.
I'm Dr. Preeti Malani, and I've been speaking with Dr. Joshua Osowicki and Dr. Theresa Lamagni about the changing epidemiology of invasive group A strep infections. You can find a link to the articles in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.